Hiya, I'm Teoh, obstetrician, gynecologist, fertility surgeon and doctor in Perth, Australia. In this video, I'm going to talk about miscarriage. Specialists like myself would see miscarriage very often. Every week, every few weeks, we do see miscarriages. However, it is still very heartbreaking for women or couple. You do see many descriptions in the past saying it's like a knife go through the heart when the doctors say there's no heartbeat. And they say, look, some people just try to brush it off. They got from people trying to make them feel better. Try to brush it off and say, it's just like a period or something. But in reality, for many, it's not. It's like a loss of a life. And each time when I see my patients, I would, with miscarriage, I would basically let them know whatever I say, I'm trying my best to help them to feel better, but I may not be successful. I can help them to look for the cause if need to and give some advice on what we can do to help. But I do empathize, and I can only imagine it is extremely heartbreaking. They might need quite a while before they feel better. Now, how often is miscarriage? I mentioned we see it very often. It's about 1% in the background. For people to have recurrent miscarriage. So some women might have 2 or 3 miscarriages in a row. So even up to 3 is about 1% of population. So if you do my job, you do see many women with lots of miscarriage or miscarriages. Now for each pregnancy, how often would a woman have a miscarriage? It very much depending on age. For women in the early 20s, about 10-11% of a pregnancy ends in a miscarriage. Whereas if for women in a higher age group, like 40 and above, up to 50% of their pregnancies actually end in a miscarriage. I've made a few notes here. I'm going to go through them. So definition of recurrent miscarriages, very much depending. Number one, what's considered as pregnancy for some doctors or researchers, or you have to see something inside the womb by ultrasound scan, a sac, that before you consider, if they lose it, a woman lose it, before you consider that as a miscarriage. Whereas for some researchers, that means you have a positive pregnancy test, that's considered pregnancy already. So if you look at anyone who has a positive pregnancy test, and they end up with miscarriages 3 in a row, is about 1%. And when should we start doing tests and such? Usually after one miscarriage, we would encourage the woman to try again, to say, look, it's because the numbers are there. It can happen for many people. You get all the support we can give. Try again. However, of course, if they give a story, there's something really obvious that can cause miscarriage, or if they have more than 1 miscarriages, maybe 2, maybe 3, then you really need to consider doing more tests. Now, there's this theory, on one end you have subfertility. It's a theory on receptivity of the endometrium. Basically, on one end, some people just very hard to get pregnant. What the theory is, the endometrium, the lining inside the womb, don't really accept the embryos very easily. Basically, most embryos, even the perfect embryo inside the cavity in the womb, in the endometrium just don't accept it for any reason. And on the other end, I've seen patients who every month they start trying, straight away they get pregnant, but they end up with miscarriages most of the time. It's like on the other end of the spectrum. One end, fertility is the endometrium not accepting any embryo. On one end, basically the endometrium, the lining is too lenient for any embryos there, even its abnormal ones, very low quality, they accept it anyway. But of course, when the embryo is not healthy, end up not growing normally, and that results in a miscarriage. Now, this topic has been presented by my colleagues, especially in the UK, a research group. However, in general practicing, like, day-to-day clinic, when I see my patients, there's no specific test at this stage I can use in my day-to-day practice. Of course, in research, we look at different things: immunology, immunomodulation, and such different cells inside the womb. How can we optimize them to make them more receptive for the embryos? Now, moving on, what do we do if, let's say, I see a patient who have a few miscarriages, 2 or 3, and they come in to see me. Of course, I'm going to take a full story and do an examination to see is there anything obvious I can find straight away. For many cases, there's no, they're fit and healthy, no definite or clear reason for me to be very suspicious. That's the main reason. So I would do the thyroid test, hormonal test, which include thyroid, which is most important because underactive thyroid has been linked to the miscarriages. So if they are found to have underactive thyroid, certainly it would be useful for them to take thyroxine hormones to boost it up to protect the pregnancy itself. Now, number 2, I would need to do chromosomes. Chromosomes basically is a building block for genes. Think of Lego, where they should go to the perfect place for each piece. And for chromosomes, a normal woman will be 46XX. For men will be 46XY. So you can, sometimes even for us, we have abnormal genetic composition, which is not the usual arrangement, like one bit can be detached and then stick to somewhere else and such. Then, when you do chromosomes, then you want to find out those, because anyone with abnormal, even they have the same number of genes, but they just stick to the wrong place. So there's a risk that they may create sperms or eggs with abnormal genetics, then they can't create healthy embryos, then that might end up with a miscarriage. So we need to check the male as well, male partner, so men and women, both individuals would need to be checked. Number 3 I want to check for is ultrasound scan to look for anything inside the womb which may potentially affect the embryos from implanting and developing nicely, preventing the womb from nurturing the embryos. Common things, for example, you might see a polyp. If polyp or a fibroid, which is the overgrowth of the muscle, if they grow in the muscle, especially if they invade or they stick into the endometrium, the environment. So number 1, the environment can be affected. There could be some abnormal cells inside there, affecting the immune receptivity of the endometrium. The shape of the womb can be changed and taking up the space. Those fibroid or polyp might release mucus or anything, changing the environment. So if you see anything, any women with miscarriages, you see a big polyp or fibroid or anything, or sometimes they may have scarring from the past, any procedure, infection, they may have a septum. The wall of the womb kind of grow in a little bit, affecting the architecture, the formation of the endometrium. Then you might need surgical treatment to take them away. So many women with fibroid or polyp, they can't get pregnant or have miscarriages. You take them away, then there's an improvement in the chance of them to conceive, to get pregnant, and also to have a healthy pregnancy development. So ultrasound scan is important to look at the womb, the environment as well, and the ovaries to see what you can find. Now, patients with miscarriages later on in pregnancies, for example, the second trimester after 12 weeks, 13 weeks, they may have incompetent cervix. Basically, the cervix acts like a holder. Basically, of course, in labor, need to open up for baby to be delivered. Whereas during pregnancy, they need to hold on to pregnancy. There's like a sustaining and a stiff support to hold pregnancy inside the womb for 8-9 months. So some patients just born with incompetent cervix can open, or patients with cervical treatment in the past, like they have a biopsy, a big biopsy, or some because of abnormal cervical screen, pap smear in the past, they need to get a little bit of the cervix being removed, and that shorten the cervix and make them a bit more prone to cervical incompetency. For those patients, it's a different topic, but basically, if they do get pregnant, you need to monitor the length of the cervix to give progesterone support. Progesterone has been known to make the cervix support the cervix, make it a bit stronger. And some patients, if it's getting too short, you do need to put a stitch on to hold on the cervix, and we have success in cases like that. Move on back to miscarriages, especially early in pregnancies. The other things you want to do is thrombophilia. Basically, thrombophilia is conditions that make the bloods a bit thicker. They are more prone to having blood clots in the blood vessels called venous thrombosis. Some patients do have the genes in thrombophilia, or some even carry certain antibodies like lupus antibodies and such, which is associated with thrombophilia. But those conditions have been associated with failed implantation in IVF, fertility, or can result in miscarriages. So depending, it can individualized. When you find the results, look at the results, can individualize the results, and the usage of aspirin. You might add aspirin or Claxane, which is a blood thinner, which may help those patients to prevent miscarriages in the future. There are other things that people talk about, for example, looking for NK cells, immune cells, interleukin, the immune biomarkers and such. Those areas are very much being researched. We don't have a firm conclusion at the moment. Certainly in day-to-day clinic tests, sometimes you don't have a test available in Australia at the moment, or even internationally, apart from a few very specialized research centers. However, as I mentioned, when you see patients, you can individualize and do certain extra tests that need to, depending on what they tell you, or what they tell you that whatever happens to their family in their pregnancies and miscarriages story in the past. And it can be individualized, and sometimes you do try out a few things. One question is the use of progesterone. Now, there's a big trial called PROMISE trial in the UK, shows that patients with miscarriages, you just give them progesterone support in early pregnancy. It hasn't been shown to be helpful. However, there are more studies came out essentially saying if anyone who has got miscarriages in the past and they are bleeding in this current pregnancy, then you give progesterone. That is proven to lower the chance of having a miscarriage. There are also smaller studies to say, look, progesterone actually may prevent miscarriages for certain patients. So progesterone, if someone got pregnant, you give them progesterone and you monitor the pregnancy very closely. The downside or side effects of progesterone is not usually severe. Of course, there'll be cost. You need to buy the progesterone. Usually they use vaginal route, and sometimes can cause irritation and inconvenience and such. But yeah, especially monitor the progesterone a bit lower in pregnancies at this stage, or even patients looking for progesterone. I won't have a very high threshold to say no. I think, look, progesterone, number one, provide reassurance, and perhaps it's been shown a bit more in current research, most current research, to say, look, they may help, in fact. So for those patients, I monitor them closely. Anyhow, you see them every couple of weeks the most, if not every week. So they won't be taking progesterone for months and months with a miscarriage, because what we're worried about is someone have a miscarriage, take progesterone, then they won't miscarry because progesterone keeps supporting that abnormal pregnancies. If you don't see them for a month or something, then they're keeping, in theory, they have a risk of infection because the pregnancy being kept inside for too long. But once again, come back to patients who attend specialist clinics. Often you see them every so often. So if anything abnormal, then you can stop the progesterone and provide treatment for their unfortunate miscarriages. Encouragement is very important. Even even if we don't provide, if even every test is normal, you don't give any treatment. If patients after 3 miscarriages, they come to see you, you give good support and you monitor the pregnancy closely. 3 out of 4 of pregnancies would be fine. It's easier for me to say to say to patients than for them to feel more reassured sometimes, because we say, oh, you'll be fine, of course they will be worried. Just like my patients with miscarriages or fertility, it takes a while before they feel more reassured. All the tests come in, say it's normal, they go on to have pregnancies past 10 weeks, 13 weeks, 20 weeks. Slowly they feel a bit more confident and reassured in these cases. That's about it for this time, and there are help you can give. Miscarriages, once again, is heartbreaking. It is very disappointing, but there are things. What I'm trying to say once again is trying to encourage my patients, that could be you, to say, look, get help, do some tests, and we help to monitor next pregnancy. There's a good chance we're gonna be okay. Okay, bye for now.